Thank you so much for joining our February panel discussion for the International Society of Systems and Complexity Sciences for Health. We are very excited to have this panel discussion tonight, and I think I need to give a bit of credit for one of our panelists, Hub Wollersheim, for actually giving me the idea for the panel. I'm Paige McDonald, and I'm a vice chair for clinical research at leadership at George Washington University. I'm a proud member of the board of this society. And in a discussion with another group with Hub, he was talking about an assignment that he had had with students about the complexities of discerning data that's coming out on COVID-19. And when we were thinking about an appropriate panel discussion to follow on with our prior discussion, it seemed like an appropriate topic. How do we make sense of all the data about the COVID-19 pandemic? So that's our topic for this evening. So I've introduced myself. I'm going to introduce our chat monitor next. It's Jessica Moreno. Jessica is one of the PhD students in translational health science. It's the program that I primarily teach in at George Washington University. And she will be asking questions from the chat and interrupting when participants don't seem if they can get their questions in. So I just wanted to put a bit of information for those of you who may be joining us for the first time. Whoops, I'm sorry. I've gotten trigger happy. So I apologize. This was happening to me yesterday during my students' dissertation defense that my mouse was not cooperating. So I apologize. About the mission of our society, we aim to improve health and wellness for everyone across the globe through these interactions. And the next slide, so that you'll have for your availability, is about the values to embrace diverse perspectives and inputs from all stakeholders, to engage in interdisciplinary exploration, experimentation, iteration, and adaptiveness, to optimize overall health system performance, to align incentives with strategic, consensually agreed upon objectives, and to embrace collaboration and partnership despite divergent visions and missions. And so now I'll start with a little bit of the background on today's panel discussion. I've already told you kind of what prompted the idea, but the information on this slide came directly from our announcement. When our society was talking about this topic, we just raised the following questions. And considered how data and numbers have been used related to the topic of COVID-19. We are sort of hit daily on the news and with graphics and in our different organizations with numbers. What do these numbers mean? Comparisons of who's doing worse, how many people have tested positive, how many people have died today, how many people have been vaccinated so far. But what does all of this mean? And in particular, what does it mean for those persons like myself who do not claim to be data experts? How are we supposed to make sense of all the information that is hitting us in the various graphics portraying often very negative pictures of data and the pandemic? How do we make sense of this for our own health, for our ability to earn a living or enjoy ourselves in the company of family and friends? And so our panelists today are going to discuss the nature of data, the need to consider data and report them in context and to aim to interpret them so they become helpful to understand the pandemic as a whole and make sense for appropriate action. But first, let's take just a little look at some of the numbers for today. So of course, I just did a snapshot of what's on the WHO's coronavirus disease dashboard. So, as of today, there were 173,594 new cases, right? We have 111,593,583 confirmed cases. And we have almost 2.5 million deaths. And I know, most of you who are in the United States know we just went over the 500,000 mark for deaths from COVID. And the orange graphic just reinforms that with the snapshot of the picture of the number of deaths. When we look at the numbers by region, the Americas have, more confirmed cases than other regions. And these are daily numbers. And we also have more deaths than other regions. And then when we look at vaccinations, and this is from a New York Times report, and it's based on our world data. Even though in the Americas we have the highest numbers, if you look at the United States, we're only at 6% of our population fully vaccinated, much further behind Israel and some other countries. But what does all this mean? Okay, what do all these numbers mean? So our objectives for today's sense-making session are to apply systems thinking, system science, and complexity science to the topic of data in relation to COVID-19, in particular, the terms of sense-making at all levels of analysis. To examine the complexities of data in relation to COVID-19 and how those complexities impede or facilitate sense-making and action. And then to consider what we can learn from the complexities of COVID-19 pandemic that might inform future sense-making. So, and this is going to be a graphic that I borrowed from Kevin's presentation the last time we had a panel discussion about the relationship between information and wisdom or knowledge. So data, just to keep this in mind throughout our presentation, that data by itself in a standalone in vacuum is just data. It's just recorded measurements or observations. When it's been validated and interpreted within a context, it becomes information. Then when it's been analyzed for patterns and the information becomes knowledge. And ultimately, when it's applied to forecast or decision-making, knowledge becomes wisdom. So if we can just keep this in mind, it may be helpful for us. So here's our process. I will moderate and I will pose a series of questions. I'll begin with one question at a time. We will call for the first about 3 to 4 questions that we have prepared. I'm going to call on a primary panelist to start, and give like a 2 to 3 minute response. I've kind of asked the panelists in advance where they think that they can be the best at answering questions, or where their experience, not the best, I'm going to take that back. I saw Garrett's action, where their experience lends toward the content or the topic of the question best. How about that? So I clarify. But other panelists after that primary respondent can come in free form on how they would like to add to that question. And then once we think we've exhausted the panelist topics on that question, we will see if there's any questions from our viewers on that question or our panelists through the chat. Toward the end, we have questions that really relate to exploring and clarifying and what are next steps for this. And so those questions are kind of whoever might want to answer of our panelists first, and you'll kind of know when we kind of get to those questions. So I'm going to introduce our panelists beyond what's on the screen. So Garrett Brown, PhD, is the Chair of Political Theory and Global Health Policy at the University of Leeds and co-lead of Global Health. Just a few of Garrett's interdisciplinary research interests, as noted on his bio page, include global health governance, global health finance, international relations, and international legal theory. Today, he will be drawing on his experience working at the G7 and G20, as well as his time in the UK Cabinet Office COVID-19 Roundtable Group. So thanks for joining us, Garrett. Carmel Martin, MD, PhD, is a board member in our society, and she's an Australian medical graduate. She trained as a clinical epidemiologist and community physician at the London School of Hygiene and Tropical Medicine, and as a family physician in London, UK. Her interests and experience relate to person-centered care, complex illness, and health systems. She is a complexity scientist, a mixed method researcher, and a practitioner who maintains clinical involvement. And if you did not hear, she is joining us on holiday today. So thanks, Carmel, so much for being with us today. And Hub Willersheim, MD, PhD, is a Dutch MD from Radboud, Nijmegen, who worked in cardiology and oncology, but he considers himself a generalist. He specializes in as much problematic as possible. His PhD was on system interpretation and cardiovascular disease. He was the director of several departments and of 2 national educational master's programs. He was PI of 3 EU programs and guest professor at Leuven University in Belgium and at Imperial College London. Hub notes that his motivators in his work are taking care of vulnerability, decisional ethics, all types of obscure qualitative analysis, and philosophy of science. His motivators in daily life are biking, long distance walking, running, traveling, art, literature, and music. And Hub loves data. So that's good. So our first question is for the panelists is, what factors impede our ability to make sense of rapidly emerging data during a global crisis, such as the COVID-19 pandemic? And Garrett, I think I'd like to ask if you would like to weigh in on this first. And if there's a slide that you would like me to refer to, just let me know what slide that is.
The slide will come later when we'll be horrified about how the process worked at the UK Cabinet Office. But I think the factors that impede our ability, I want to just go a step before that. This sort of assumes that we know where the data is and we know how to capture that data, that it's not incomplete, poor, or corrupted data. So one of the problems that we had in the Cabinet Office when I was working with them was not only the multi-sectorial and multi-level sort of complexity and social complexity around the acute health emergency and the challenges that we were under to make decisions under imperfect information. We didn't actually know where to find the information we needed quickly. And besides the limited information that we were confronted with, we had conflicting evidence from credible sources. So there was sort of a battle of epistemic authority that was taking place within a lot of the discussions that we had. And one thing that became very clear to me is how do you use siloed or pinpointed research and synthesize that quickly to try to come up with a more holistic understanding of the problem, and to do that in real time, in hours and days and not months and years, and how to interpret that data, what data was available in relation to other factors or other areas where there was less data, or with other areas that were with more data. And I just want to give one quick example. During one discussion, a representative from the airline industry, and yes, people like the airline industry were involved with these discussions, gave very quick percentages on losses. And they had a case study from the Icelandic volcano, which shut down the airspace in 2010. And they were able to give us a very compelling argument for the impact of lockdown and travel restrictions. Now, I think this was in February. So, early on when we could have been more aggressive. The epidemiologists on the panel were giving a lot of, self-proclaimed guesstimates, a lot of hedging bets. And so what the decision makers who are, our politicians had to deal with was to interpret that information in real time. When you had an industry that could draw upon data very quick with case examples, and a group of people who are trying to find something that's emergent, that's novel, right? It's a novel coronavirus. They were not quite sure what was taking place. So I think these were some of the major factors that impeded things. And so you had battles for epistemic authority, you had variable interest involved, you had balancing under imperfect conditions of information, and then you had the power of public opinion. and the media, which was putting a tremendous amount of pressure on some of the lead scientists that were in the media spotlight and the policymakers that were trying to sift through this information and being extremely cautious about lockdown in terms of infringing on civil liberties, which I know is a question that comes down later in the presentation. So for me, those are real-time political factors and social factors that impede our ability to use data once we even know where to find it, and who are the right experts to bring into the room, and who has access to the conversations. These sort of foregrounding issues, I think, are major when we're talking about making sense of something like COVID-19 under very rapid changing circumstances.
Yeah, just to, a quick comment from the chat. David makes a good point of how do we even know what data that we need? Yes, where to find it, but also what are we even looking for? So thank you, David, for that.
Hub or Carmel, would you like to weigh in on the question, add anything to what Garrett had to say? Thank you, Garrett.
Well,
yes, I'm coming from the perspective of being a consumer, and I think one of the other factors is actually health literacy in the general population, data literacy in the general population, data literacy in journalists and people in social media, and people wanting to be actors and leaders in a very complex and chaotic environment, and people wanting to make noise and get attention. So I think it is, given all the complexities on the side of the data, there's also the use of data or incomplete data and people making capital over that. Particularly social media and creating anxiety and sensationalism.
Hub, I think you were going to weigh in as well.
Can you hear me?
Yes, Carmel, we heard you. Thank you so much. I think, and just highlighting, you're highlighting more competing interest from epistemological, and now you've pulled out potentially political and then social and economic capitalistic issues as well, right?
Yeah. And also educational. I think that this also highlights our, and it varies in different countries, but the lack of science literacy and not just health literacy, but science literacy in the general population.
And I like the word that you mentioned, data literacy, right? Because how to even read and interpret data is something that goes hand in hand with health literacy. For those of us who's ever designed an infographic, right? Having to think about what are numbers going to mean when we put them on a graphic. So I think that's a good point as well.
And the point is that I think that all the arguments about hypothesis testing and etc. But the thing is to know that data is not knowledge, going back there, and to know that things are hypotheses when things are changing and emerging, that we should have more ability to understand that in the general population.
So Hub, I think that Carmel may have set you up nicely for the second question, but do you want to weigh in on this one first?
Well, perhaps a little bit about psychology, because ever since human took over the power over Earth from God, we want to control and manipulate. And biology and science helps us with that. and especially simple numbers and simple way of thinking, like monocausality, effect outcomes, as just a one-step thing, biological data, and scientific approach from natural sciences helps us to think that we are in control, and it takes away the negative feelings we have about risk, anxiety, perhaps even panic and fear. And it confronted me with something, a kind of fear of death. People were panic about dying, especially people where I spoke with from the hospital. And that's a kind of obsession in Western society, that we don't want to die. We think that death is something painful, that we will die short of breath, while over 90% of people die in peace and harmony, and they're grateful for their life. So it's also a psychological thing that occurred in society, that was a little bit strange to me, and that impeded our ability to make sense of the data.
Thank you. I think that's an important component. And I think, going back to Kamel's point, that the competing interest in social media leveraged that for their own benefit, some of those who were misusing the data, so to speak.
Yeah, and what I, in the media coverage, of course, often is excessive, because that's the way that they maintain themselves. But it was also militaristic. We were in war. We didn't know exactly whom the enemy was. There was a big fight. With vaccination, we will win, etc. So there was a lot of militaristic thinking around it in the media coverage.
If I can weigh in on that point, and academic egos were certainly involved, but political egos are certainly involved in the decision-making and the deciphering of information. And what ended up happening, at least in my experience, was what sociologists call imprinting and pathway dependency, where vested personal stakes had been put onto certain graphs or use of data or models, particularly projection models. There was a lot of personal capital at stake, and this created a lot of entrenchment and imprinting, where they just became pathway dependent. Like, this is what we're following, and this is what we're going to do. We have too much political capital invested in this now to turn back, and I think that's stymied the use of new and emerging evidence to rethink positions and sort of reevaluate current practice in light of new evidence. I think that was very much a problem. And going back to Hub's point about the wartime dialogue, a certain member of the UK Cabinet Office, who is very senior, said that the British people will beat the disease through the resiliency of the British population, or the resiliency of the English. And that is a Churchillian sort of reference and a wartime call. And what I loved was one of the response from a virologist in the room, which I think was a subtle, F you to the politician. He said that there was no evidence to suggest that the English had a genetic disposition, and then went on to say that there was no evidence to suggest that exposure to prior coronaviruses would lead to an increased immunity response. And he took it literally. as you know, the British people have a built-in resiliency. But so that type of rhetoric and political grandstanding certainly blocks or impedes the use of emerging evidence. That's my added to that.
And I will only say no one experienced that in the United States, correct? A little bit of sarcasm before we move on to question 2. Okay, so there's a lot of questions here but data crunching, and this is where we've asked Hub to weigh in first. Data crunching, what is it? How might it help solve complex problems such as the COVID pandemic? And so we have lots of sub-questions here, and I'm going to let Hub weigh in on wherever he would like on the sub-questions. Where can it help? Where can it help? What's the role of data sharing? And how did the complexities of data gathering analysis impede the management of the pandemic? So some of these things we've already touched on, but I'll turn it to you, Hub.
Well, I don't know where to start with, but I think that we should first say that simple data and simple algorithms are okay for simple problems. So if you want to predict the number of hospital beds or ventilators or ICU beds, then a simple algorithm full of biological data might help. Where it can't help is if you're asking yourself if you're really helping the people that come into the hospital beds, the ICU beds that are ventilated. We did a small type of research in the Netherlands because the ICU beds were, I think, like everywhere in the world. We saw the pictures from Bergamo where they were overcrowded. We faced the same problem in the Netherlands because we are a cheap, efficient country. So we have a minimum of ICU beds. And already at the end of February, we were overflown by patients. And then a GP where I talked with said, is that something that is needed, an ICU bed for an 85 years old patient with 4 types of diseases, who doesn't feel attracted to life that much anymore, knowing that he has a chance of dying of 50% in an ICU unit where no visitors, the people that he loves, are allowed. What the GPs in the Netherlands did, that was that they started a kind of pre-ICU conversations with their patients and asking them whether they really needed an ICU bed. And over 60% of them refused to go to the hospital to be admitted to the ICU. So that shows a little bit how a different look at data and background information gives you another view on the problems around COVID. Another thing, what I like very much about the questions is the role of data sharing. Because we did some data sharing projects in the Netherlands versus Scandinavia versus the US, and that proved to be very difficult. Not only because we had different databases, although we first thought that we had the same type of databases with the same definitions and with the same ICT mediums. And while talking about these definitions, that we use the same terminology and, let's say, understandable background on it, that proved to be very, very difficult. We even wrote an article for the JAMA about that. In general, data sharing asks for trust and cooperation, and that is something that in the current state of societies is something that we are missing more and more. I see that within the European Union. I see that in the work that we do together with our British friends. We see that if we work together with states that have more of a populistic leadership, that the background for sharing, trust, and cooperation is eroded, and that's terrible. I'll stop now.
Thank you, Hub. Carmel or Garrett? Okay, Garrett, go ahead.
I'm happy to go. I mean, I was very happy to hear that. I mean, I have to say I was apprehensive to join you guys because I thought this was all going to be about, you know, big data and all this algorithmic stuff that I get at my university. And I was thinking, oh boy, I'm not going to be able to say anything. But I think so. I mean, where might it help? I think it was nice of Hub to say that because I think it can give indications and projections. It can show trends. But what it can't give you is explanation or predictions beyond sort of linear quantifications. So, for example, Neil Ferguson from Imperial was the one who modeled the prediction of 250,000 deaths and ran a couple of other spurious models. And they missed something quite interesting. It couldn't account for super spreader events. And so there's a small city in England called Bradford, which has a very high Pakistani population. And we saw a massive spike in cases in Bradford. So what it could do is it could catch, the data caught the spike, but what it couldn't do is tell us why. It was the social scientists who went in there that found out that, oh, they're still holding these large religious and wedding ceremonies. The Muslim population is still having lots of social gatherings in each other's homes. You know, there's these unofficial nurseries that take place between families where on rotation, where they'll have like, you know, 15, 16 kids, and then the next family will take it for a few days. So they have these rotational informal nurseries. And this just couldn't get picked up by the data. All it could do is show us the trend, but it couldn't show us the explanation. I have slide 29, if you don't mind showing that.
You guys just pause for just a second while I go to presenter view. Then I can find 29 more readily. There you.
So if the question is data crunching, it's, yeah.
Oops, I'm sorry. There we go.
There it is, 29. I don't know if you can read that, but if we're talking about data crunching and the use of data, and you're trying to use, you know, come up with projections, predictions, and to answer questions, this is actually, it's because the document's confidential, I reworded it. But this is basically a snapshot of what we were given to try to think through in February in the UK about what we could say about a best case, middle case, or worst case scenario. So this was given to us, not with advance notice, and there was 27 of us in the virtual room. And we were told to read this, take notes, and go see what we could find to help answer the questions in terms of where we thought we were going in terms of best case, middle case, or worst case. Now, if you look at some of these questions, I mean, you have stuff about GDP growth, trade volumes, how will it disrupt low and middle income countries? How do you think, what effective therapeutics will there be for reducing mobility? Will we have initial peak followed by a series of small peaks? Best case, worst case, middle case. I mean, it's interesting. It's interesting that this is how we were approaching the problem, or we were told to approach the problem by civil servants largely. And how do you, within a week, within 7 days, take this in and try to find what you need to say something intelligent about where you think things are going in February of 2020? And I don't know what data crunching I could have done to answer a majority of these questions, let alone, where I would find evidence bases. So I put this, I have a global health group. We have 450 academics that we're in charge of. We pool resources. And so we put this out there, and we were able to come up with a report that answered, a good number of these. And, we were 25% accurate on most of our thinking on it. I mean, we got some things right. We got, a lot of the worst case stuff happened. Anyway, I just thought this would be interesting for you to see that, how may it help to solve complex problems? Well, this is the complex problem in a nutshell. And I don't know how it could solve this problem easily or effectively, because we certainly got it wrong.
Yeah.
Thank you, Garrett. I'm going to switch back to the next question.
I'd just like to weigh in a bit on a very practical level. As someone who's doing data analysis and looking at hospital admissions, etc. So one of the issues is the definitions. It's been mentioned before. If we go back to actually data collection and data definition and taxonomies. So what we've got is, I published a paper on hospital admissions, and what a hospital admission is in one state in Australia is not what a hospital admission is in another state of Australia, isn't what it is in different states in the US. What an admission to an ICU means in one country isn't the same. So we're actually, and death, how death ascertained, how is a death due to COVID ascertained differently in different countries? So that I suppose this is a going forward issue, that the problem with data sharing is that we're talking about apples and oranges, and maybe this will be a way forward. And if the WHO or other bodies have more power, or more influence rather than power, we can start to look at these data definitions, because the whole thing becomes fairly meaningless if you're all talking about something different. And countries, comparisons are odious across different states, countries, etc., etc. So that was just my comment as a practical, my practical epidemiology background, that data definitions are very important and there needs to be consistency. Even so, you can't account for context, but at least you can have similar definitions. That doesn't account for all the other services that might be available in the community, that might in some places become an admission, in other places would not become an admission. What hospital in the home programs might prevent people having long stay, and even going to ICU. So depending on what home and community services are available, hospital in the home. So the whole thing about the impact and data sharing really needs to be rethought in the future.
If I can
That's
add
my
to
comment.
that, I mean, the evidence is beginning to come quite clear that there were multiple variants and knowledge about the epidemic in China much prior to the release of discussion at the global level, which is, part of the IHRs, which is, is supposed to be calling the alert within a certain time frame and to send virus samples. And if you've done the sequencing, which they had done, that should have been released much earlier than it was. Now, I knew about it in November from a colleague in Wuhan. So that means that this is probably circulating in late summer. Those several months could have made a massive difference in terms of knowledge, or at least of having a better idea of what the virus was, its genetic sequencing, so we could move on that. When that, it did get released quick, and there was a lot of data sharing between existing networks, which was great. But I think that was a major impediment, and I think it could have bought us quite a bit of time. That if the alarm would have been announced in November instead of December, would have made a big difference. 4 weeks would have made a big difference. And the IHR also has travel. I think it's Article 47. They're supposed to align travel information sharing between countries, and that wasn't done either. Everyone just went alone. Everyone just entrenched and went to national initiatives. And so there's a lot of regulations that are supposed to sort of mitigate these factors and help facilitate cooperation, and there just wasn't compliance. So one of the problems is compliance, and data sharing is one of those compliance under the IHR. But,
So compliance might be one of the simple rules we want to talk about as we move to the next question, right? Or think about, because that is how do or did the focus on infection and death impact the simple rules for managing the contagious? Social distancing, masking, data as a way to focus the mind, creating fear, a tool to control or manipulate. I think these are the negative things, but I think Garrett's point about compliance with higher level organizational rules, or rules that have been set for at the international level, and then going into isolationism by nations for control raises the question of how that influences kind of the simple rules, right? That we operate as a global society. So Hub, I do think you raised your hand to start first on this, but I may not have set you up well. So, so you can shift the thinking from what I just said, if you'd like.
Well, what I've seen in the Netherlands is that the data were primarily used for, well, let's say arousal. And there's something good about that, because then it gets attention, it stresses, and then you choose between fighting, freezing, or flying. And these data were translated into, let's say, rules. I found that as a free individual very striking, because what I do like are principles, and then principles on which I can act and translate that in context-related behavior. And that's different from rule thinking. Another thing is that data were often presented just as data, even not information, even not trying to explain things to the Dutch people and to provide understanding, because with understanding we do not only need, as you already said, data, we also need words, we need sentences, and we need stories. And that all together gives a kind of mixed method explanatory framework. And that was something that I missed a lot, at least in the Netherlands. It was better in Germany. I'm half German, so I was also a little bit involved in the German way of thinking and acting. Leopoldina was an initiative in Germany, and they had much more a kind of explanational type of arguing, while the Germans like rules, as we know, and the Dutch don't. So that was very strange that the culture of the population and the way that they gave their information was not really connected to each other.
Sorry, I would mute myself. Thank you, Hub. Garrett or Kamel, do you want to respond or add something of value?
I can. So I'm obviously focusing on the negative, but I do think that data can focus the mind in the sense that it can show trends and it can show worrying trends. And I think very much in the beginning of the pandemic, people were pretty on board in terms of what was emerging was something to take seriously, needed to be balanced with other social factors. There was a general interest in getting it right from the beginning. But this is what got why I was no longer invited to the roundtable discussions anymore, was an incident in November 5th, 2020, in which the Scientific Advisory Group on Emergencies, which is the group that advises Boris Johnson on COVID and on any other emergency. So the group is quite, multifaceted. It's not just health-related emergencies. It could be climate or flooding or whatnot. Released a projection on the media saying that 4,000 deaths per day would occur by December if there wasn't a second lockdown. And this number was used to justify the second lockdown. However, within 24 hours of that public announcement, it was discovered that the Scientific Advisory Group purposely picked the reasonably worst case scenario in their projection. And instead of using three other models that are usually kind of used together, and they kind of read them together, which had 1,000 deaths per day. And those were based on sort of assumptions using data coming out of Spain and France, which was about 2 to 3 weeks ahead of the UK in terms of infection rates and deaths. The news broke that SAGE had done this, and the BBC found a whistleblower, wasn't me, who was involved in these conversations. And they got Paul Whiteley, the guy who runs SAGE, to admit that they used that number specifically because they thought it would gather the most compliance from the public. So they purposely went for the worst case scenario in that. Now this goes on to the media. And basically, the subtext is you're trying to scare people into compliance. Now, what I had a problem with it is I didn't think it was using evidence we had from Spain and France properly. I thought it was short-sighted and counterproductive. I thought it would erode trust. And the evidence does show, at least in health, that trust is a major component of compliance. and that it would harm other data sources and other authorities who maybe were making better and more reliable projections. And it also fed into conservative backbench ideologies about libertarianism, which need to be balanced, but it obviously gave them ammunition. And also we saw a surge on social media of conspiracy theories around the use of science to manipulate. It played into all those narratives in a way that I was no longer interested in being part of. So that was my last kind of hang out with those guys. So I think when we're talking about creating fear or tool of control, I mean, I have firsthand experience of seeing how those decisions were being made and how you could take these 4 models that a lot of people have worked on, and something as simple as, well, we think this will sell with the British public better, won out. And not by sell with the British public, it means scare the British public more than this other model that was, or the 3 other models that were predicting something far less than 4,000. And that's a big difference, 4,000 people a day versus 1,000 people a day. Neither one of them proved to be right. But yeah, so I think data can, and this graph that was on the BBC was quite powerful. And you have these 2 epistemic authorities who are running SAGE. And when that gets eroded, that whole narrative gets eroded, I think it's quite dangerous. That's all I have to say.
Well, I think you obviously know in the United States, and I don't know how the data was being generated, but the stories behind data, we were obviously getting mixed messages on the nightly news from the highest levels in our government, right? And sometimes in the same press conference from 2 different persons with 2 different authorities, right? There's the epidemiological perspective and the political perspective, and the same number telling different stories. And so making sense of that in a critical time was impeded severely. And I think that's an underestimate of that. But Cromwell, you unmuted. So did you want to weigh in? Now it looks like she's locked up a bit. So
Hey, Paige, I want to just make a quick comment from the chat. David had a good example of a governor in Ohio where there was apparently a man with COVID-19 went to church in mid-June, and then 91 other people got sick, including 53 who were at that service. He gave a comment saying how significant it was. It's very scary. We know that our faith-based leaders want nothing more than to protect those who come to worship. To illustrate how one infected person can spread the virus, state health officials released a color graphic showing how the cases radiated to some who weren't even at the service. So really just, showing that data in order to, either scare or, whatever the case may be. It may not have been the best thing to do, but also Joachim had a good comment of, how do you communicate these uncertain and emerging phenomena? And isn't that one of the things that we need to consider going forward in the future?
And you don't want to, you don't want to cry wolf situation where you use these tactics, and then when something really bad is coming, which is highly infectious, beyond measles, like super infectious and super deadly, and you erode that trust, then you're really screwed. So you gotta hold it properly. And I mean, it's it's always good in hindsight, but I think that's a big fear that I have, because I think if I saw this chart and it was relatively correct, then that would get me to comply. But you want to do it in the right times, and you don't want your scientists to say, yeah, we took the most exaggerated number possible because we thought that would work. That's not what you want to hear.
Oh, this is shocking.
So why don't we move on to the next question? Because I think we've highlighted some of the difficulties of communicating data, and I like Joachim's question about how do you effectively communicate these emerging, what you know about these emerging situations with, and I would add, without eroding trust, as Garrett's pointing out, right? Because you want to communicate them in a way that instills trust. I think that this is where some of the language that we have in complexity science about emergence and about recognizing patterns now that might help us going forward. I mean, there are some of the tools and the principles that we have that can be helpful. So that's kind of what our next question is related to, is how could complexity science create insight into the rapidly emerging data during our global health crisis, such as the pandemic? And I think I've asked Carmel to take the lead on responding to this question first. And Carmel, just let me know if you want me to pull up a certain slide.
Yeah, could you pull up 27, please?
Yes, ma'am.
So I think that what all this comes down is what we call sense making. How do scientists make sense? How do politicians make sense? How do the public make sense of this emergent problem of the COVID-19 epidemic? So let's go back to how it started. So first of all, as Garrett said, it was unordered, sparse, fragmented information. We didn't know what data we needed. We didn't know what data we had. There were sparse, fragmented data, contradictions, emotional responses, and possibilities. And in the Cynefin framework, which is over in it's that little diagram. I wondered whether I should make a big one of this, but there are 5 domains. There's this central domain, which is what we call unorder. So we don't know what's going on. And then we have the next phase would be chaotic data: initial, rapid response, sporadic, inconsistent, evolving, and emergent. And this is where I think that the emotion really kicks in these first 2: panic, fear, command and control responses by national leaders who want to show their power and strength in getting in control. However, we then move into a sort of areas where you start to get fuzzy information, and it starts to become, there's in multiple different values, uncertainty, assumption, multiple stakeholders and competing goals and needs. So that as the situation clarifies, you still got complexity, but there's more information. There's actually information as opposed to data. We then move down to sort of more sort of structured. Experts have got confidence in some of their modelling of evidence across different contexts. There's systemic analysis. So the example is the use of masks. There have been numerous systematic reviews on the use of masks, and one of the most telling was one in the JAMA, where they reviewed multiple layers of evidence, multiple types of evidence. They looked at dispersion, airborne transmission, little trials of using masks, etc., experience from previous pandemics. So it's very complicated, and again, there's no easy answer. And what everybody wants is simple, clear data, binary questions, clear evidence, which are context-free. And here we have randomized controlled trials of vaccines. So this is the multiple layers. These are the different ontologies in a complex system. And sense making in health systems means that at every level, we have these different processes going on, from the health system level, health organisations, clinical care, personal health journeys. And all of them involve structures, information, goals and values. There's different techniques for making sense of the data, turning it into information. And sense making is the process of converting this into knowledge. So the next slide, please. So this is what Joachim and I did. This is a published paper. We did a mapping exercise of some of the types of questions. Now, this is a few months old, so this would have already changed. But at the time we did a mapping exercise at the sort of questions that are posed by, that might be answerable or constructed within the framework of a simple, obvious. So one is risk factors, social economic status, age, multimorbidity, etc. So risk factors, that seems to be something that has come out, although that changes when you've got you've got a huge sway of the population infected. Some of those things change, although the patterns probably remain. Understanding the virus is expert focused. What are the genomics? How do we make sense of the emergence of different viral strains? Ongoing, not simple, but hopefully understandable, knowable. Whereas in the emergent level, the need for hospitalizations, the need for ICU admissions, medication choices, prevention, asymptomatic spread. How do we deal with asymptomatic spread in non-vulnerable populations? Do we, like in Australia, where talking about the use of data, Australians, because we have the only cases we have coming in are people from overseas. We have no community spread other than outbreaks from quarantine hotels. So Australians are actually glued to these number of new cases, number of cases that are community spread. So that's an emergent phenomena, and people tend to make sense of it as though it's in the simple domain, but in fact it's probably in a very complex environment. And fuzzy, chaotic areas where, you know, we're not going to know, we're never really going to know and really make sense of it, but there's some patterns we can learn about the history of COVID. So this is the Cynefin framework and a way of making sense. So there are many other sense-making frameworks. There's Brenda Dervin, and there's people who use data modelling, so using data alone. But really, as we can see, so much of this is socially constructed, and even the data we collect is really socially constructed. So overall, we live in this complex, socially constructed framework. So that's my statement. Got lost here. Hello?
I'm sorry, I was muted and I could not get to my unmute because of the slides. Hub, did you unmute?
No.
No. So thank you, Carmel. I think that Cynefin is a framework that I use to help my students understand the complexities of certain health conditions and I'm going to ask your permission now to share with this slide with them in your and Joachim's presentation, because I think it's an excellent illustration. So, anyone, go ahead. Was someone speaking?
Sorry, it was a bit of a delay. I said you're welcome. It probably needs to be updated. It's not a static. As I said, we did this some months ago, and things have already changed, and things will move through the space of unorder. So that very interesting. The space of unorder is the most important sense-making aspect, is where you can be creative, you can, look at the whole picture, but you can move things across different domains as the situation changes. And the space of unorder is the space of possibilities, where you can be positive and creative and not be just weighed down by rigid frameworks.
And I think the point that you just made about things will move, and they already have moved, I think that's one of the difficulties being a consumer of knowledge and being in the United States. And going back to Joachim's question about how do you communicate emergent phenomenon, I think that's one of the difficulties, because I think someone else mentioned it, I may not be remembering it. People want to know what to do now. They look to people to give them advice based on the data, to take the data and give it some meaning and tell me what to do now. And it's hard to give them those concrete answers or the simple guidelines or principles to follow when the data is emergent, and the information is emergent, and we gain knowledge over time, and new knowledge may change advice that we would have. And that was definitely the messaging in the United States about masks wearing early on. Our messaging changed based on even from Dr. Fauci himself, right, who has become one of the greatest proponents of masks. So I think that goes back to the overall conversation that we're continually making sense of data and with new and emerging phenomenon, but how do we then communicate it so that people can take actions and then remain open to modifying those actions? So that's a question for anyone, I think. If you will just give me a second to get back to the slide questions, the next question. So I think this is where we start moving into, this is whoever would like to talk first. Okay. Is what did we learn from the complexities of the COVID pandemic that might inform future approaches to making sense of data, or offer insight into helping the general public make sense of often competing messaging related to health and data?
I'm happy to have a go at this, because I can show my other slide, which is 26.
Okay. 26.
I just wanted to bring this to your attention, because I've done a review of different sense-making approaches in an article I wrote. And I think Brenda Dervin, who's an American and probably not so active now, but was very, very prevalent, or very important a few years ago. But I think she has done a nice outline of how you make, like, sense making and going forward. So I just thought this might be a way of thinking about the future. So these are the phenomena, the current, what is your current situation? What's the history? What's the experience? What's your past horizon? What's your present horizon? Your bridge, ideas, cognitions, thoughts, attitude, belief, values, feelings, emotion, memories, narratives. Sense making and sense unmaking. So what do we make sense of in the future, and what do we forget that was in the past. And we need to recognize that there's always going to be a gap, questions, confusions, rips, muddles, and anger. So outcomes, so then we get to outcomes. So this is the process. This is just a map of a process of making sense of how to go forward. So I thought I'd just put this up before people dive in with more concrete suggestions and ideas and recommendations, because I think this is sort of an interesting framework. Thank you.
Thank you, Carmel. Anyone else want to weigh in? I'll go back to the original question slide. Garrett?
Sure, happy to do so. I mean, I guess this kind of answers another question, which are what are the biggest lessons learned? Because I think it answers both of these questions. I mean, I wrote something in the BMJ on this. I think we're suffering from 4 entrenched paradigms that have been, I think that has stalled has created stagnation in our thinking on preparedness, prevention, just our conceptions of health in general and global health. And those 4 paradigms, there's an absolute obsession in policy. And I think COVID as well has exposed this with academic research on acute health emergencies. So I just did a scoping review for the WHO on the relationship between health systems and health security, and found that overwhelmingly, if those concepts are used together, it focused on acute health emergencies. It was like 87%. And the only 2% was on non-communicable diseases. So that whole literature that's talking about health security and that makes mentions of health system preparedness, usually not much about prevention, is absolutely assessed with acute health emergencies. And you see that with the COVID numbers. You know, what is it? The number you brought up today was 2.5 million. Well, that's malaria every year. So, you know, there are other health risks out there that are year on year killing numerous people, but they don't have that sex appeal that something like COVID has, and become self-perpetuating. I think that sex appeal, and I think so. We have this obsession with acute health emergencies. I think we also have this paradigmatic obsession with state-centric, short-term notions of sovereignty, global governance, and cooperation. I mean, our global institutions just absolutely failed at the global level. I mean, they just absolutely, the IHRs, I mean, the United States, France, Spain, the UK, China, everyone violated the IHRs, and they're not fit for purpose. And the whole indexing exercise around that, the United States came in number 1 and the UK came in number 2 in terms of preparedness, and yet they weren't very prepared. So there's this bias, this almost Western bias about the burdens come from somewhere else, the risks are somewhere else. We have the technology, and you know they have the capacities, but not the ability to adapt. So there's problems there. An absolute, paradigm obsession with Pasteurian vaccine discovery versus prevention and upstream determinants. And I think that is something that needs to shift. We just sat around waiting for vaccine discovery, and we just sat around without even thinking about manufacturing or distribution problems until the vaccine was within sight. It was so, it just baffles the mind that there were so many things we could be doing preventively before this outbreak, but certainly during, that could have been done to reduce some of the problems. And yet, you know, we were just obsessed with vaccines. And then this Western-centric notion of risks and health burdens. This literature review we did for the WHO just shows that something like 92% of the articles were about the problems there not coming over here. And this paradigm needs to shift, because the problems, at least COVID-19 has exposed this, is they're here. They're not so much over there. There's some African countries that have absolutely outperformed the UK with low-cost initiatives, having a lower age median, all that other stuff, contextual matters matter. But I think there's this obsession. So I think what do we learn from the complexities of COVID pandemic? And one of the biggest lessons learned is that we have to rethink these paradigms. And there's another question on where I think that should be. I'll get to that then. But I think these 4 paradigms are absolutely stagnating our ability to move forward. And if you think about in 2015 at the G7, Obama and Merkel, and I was at that G7, said Ebola was a wake-up call, never again. They started the global security agenda. They started the PEF, the Pandemic Emergency Financial Facility, an absolute disaster through the World Bank, never used. These things were just not good models because they were stuck within these 4 paradigms. And until we break that, we're going to have more of the same. So I think that we could be way more prepared. We could have better eye on prevention and upstream determinants, a more holistic approach to health systems and how health system actually enhances security as an investment, not an expenditure. Okay, moving on. Sorry, ranting now.
I think you have a captive audience, so thank you, Garrett. Any questions, Jessica? So are we ready to move on to the next question?
I think we might, can you go to the next slide real quick? I think we might be. Oh, okay. Well, maybe we can wait till we kind of open it up to the audience, but Joachim had some good comments about, not bringing us back to the point of not having a system as a whole, like looking at that sort of view. So we can, I don't know if we want to invite him to discuss that now, or we can wait till the kind of the Q&A sesh.
Because I want to be aware of time. We always plan for more questions than we have, and we're at 60-18. And so I think we could pause, because some of the ideological differences that I had on this slide have come out in some of our discussion. So why don't we pause here and let Joachim make his points that he had in relation to the prior slide, and then we can see if we want to go on and kind of conclude with maybe this question here. So Joachim, you have the floor.
Thank you, Paige, and thanks to the panelists. Fascinating insights. I guess what came out for me out of the discussions is that we are really have approached COVID and still continue approaching COVID, as Garrett alluded to, from a reductionist perspective. What I'm fascinated by is the historical development. Newtonian science is well and good for the physical world, but it was only 100 years after the paradigm emerged that Humboldt and Goethe pointed out that in nature these laws of so-called laws of nature did not apply, that you can only understand a problem of the living world by taking the problem in its context into account. And Humboldt was obsessive. Every physical measurement he did, he always also recorded the external context in which it was taken. And it has led to very important insights at the time, which are valid now. Today, ecological sciences still uses his measurements as reference points for change. So in terms of looking at things like a pandemic, if we don't understand the context in which we live and map it out in terms of what are the relationships, what is most likely influencing what, we will never come to the point that Garrett in his final musings was alluding to, of getting a sense of being able to manage the problem as a whole. And by not portraying, it was sort of a comment I made earlier, in terms of how do we communicate. If we don't communicate the issue as a problem in its whole context. We will never be able to gain any trust or maintain any trust in a changing environment. I'm curious to hear what others have to say on that outside or panelists. I'm not sure what the solution is. As Einstein said, I don't have the answers, but I understand the problem. And I think that's a pertinent point to keep in mind from all various backgrounds and experiences, as all the panelists have pointed out. We have a fairly good idea what the problem is. I'll leave it at that. Thank you.
And I think anyone should feel free to unmute and weigh in if you'd like to comment or.
Yeah, David has had a couple comments throughout, so I don't know, David, if you want to take the floor.
Well, I think we're stuck in a trust but verify kind of mode which basically says there is no trust. And how we're going to get that, I wish I knew. I've been watching the U.S. become more and more polarized, and we can't even agree on facts, much less opinions.
We can't agree on how we define what a fact is.
Yeah.
I think that's perhaps even more problematic at this point, right?
And when a senator reads into the congressional record garbage, from a QAnon website about Antifa being at the root of the January 6th riot, I mean, it's just crazy.
We can only hope that the pendulum starts swinging back. But I think the polarization in the United States, we would hope would be the extreme. But I agree with you, David. How do we build trust? And I think that goes back to Joachim's earlier point about the way we communicate. But Hub's got his hand raised on that one. So Hub, you please.
Well, one of the first things that we should do is be humble. Most people in the Western world think that science and medicine is about a kind of absolute knowing and certainty, while it is a search towards certainty, and we will never reach that. And be humble and be clear about what we do not know and what we do not yet know. As a doctor, I always was trained by my supervisors not to show any, let's say, doubt about what to do, because the patients wouldn't trust me anymore. It was just the opposite, and that's all is also found in the literature. A second thing is that, and I now make a jump to something that that struck me when I saw the comments of Joachim. That is, are we looking at the right problem? Perhaps I may say something about that from a slide.
Sure. Which slide?
Slide 24.
Okay. Here we go. Just give me just a second.
I was thinking a lot about in what type of crisis are we? And I think the crisis that we face is over here. we have a pandemic coming out of a zoonosis, and that has to do something with the way that we treat nature, and we face and connect with Mother Earth. The way that we have organized our economy, and the way that politics react or are agents in these. And I see a kind of connection between these factors that I miss in Corona discussions, because from this we could make a kind of preventive data to prevent a next pandemic, because that will come if we don't change this whole system. And a lot of people think that the vaccine is a solution to COVID-19. It won't be, because the virus will adapt and will evolve, and like the Spanish flu went into the periodic influenza. In some 20, 30 years, we will have vaccination programs in late autumn for a new mutant, adaptive mutant of COVID. So we are gradually facing a chronic problem, and we are not very well equipped for that, and we're not very well equipped for a next pandemic if we don't try to influence these factors.
I'd like to make a comment. I think that while I think that I totally agree, I think that's a wonderful slide. One of the issues, though, is bringing the public to understand this and move behind it. And an interesting, how do we address polarities, contradictions and tensions in different worldviews? And this is not a solution, but I think there's a lovely example called Liminal Space. And I first came across it when I was in Canada. And Liminal Space, as constructed between the First Nations and the other Canadians, was this space where outside of conflict, outside of grandstanding, people could talk freely. Now, I don't know where that space is in our modern society. I think that social media is a positive and negative force in this area. But I think that we need this liminal space where people can, as you said earlier, be humble. And asking humility in our current culture of, strong men, strong voices, is difficult. But I think that on the positive side, we do have younger people who I think probably are reacting against the previous generations. So I think the liminal space idea is something that we need to cultivate.
And the liminal space relates very much to the concept of Ba from Eastern writings, of the space where knowledge is shared across boundaries, right? Creating that space for knowledge sharing. So knowledge sharing.
Sorry.
And also it's going in humility. It's not just knowledge. I think it's actually emotional and identifying with the other. This idea that as long as we're okay, we'll vaccinate our people. As long as we're okay, we've all got our Pfizer vaccine. But look, forget about everyone else. So I think this liminal space, yes, is something, maybe there's hope in that area. I noticed David has made a comment.
So I brought up the issue of boundary objects to find things that are in common from which maybe that liminal space can grow. And I am reminded of possibly the best example of leadership that I've ever heard of, which was happened on the second day of the Battle of Gettysburg with Joshua Chamberlain, and how he managed to convince mutineers to fight with him by basically finding something that put them in common, all in common. And one of the things he said, that we all have value. Now, these were mutineers that he could have shot if he wanted to. But it's finding things that are in common that you can build from. So I'm actually a little more hopeful than my previous pessimistic rant.
Garrett, I saw that you unmuted before. Thank you, David.
Yeah, I was just going to say that to answer this question of ideological differences and how do you motivate finding that intersubjectivity where people can kind of come to agreement on things where they may be priorly entrenched. I mean, there's a big debate in global health policy, or at least there has been. I think it's been muted now, thankfully, about the depoliticalization of health. This was something that Richard Feacham and I argued about a lot. He was the first director of the Global Fund, where he thought everything should be evidence-based policy and depoliticalized. But I just thought that was hugely naive. And politics has such a negative connotation now, but it shouldn't. I mean, ideology is the absence of politics. The absence of politics is a state of nature, which reverts usually to the sword, as Thomas Hobbes would say. So what we actually need is more politics, not less politics. Depoliticalization is not going to solve it, but we need a certain kind of politics. And, we're talking about liminal spaces, but, I'm a big fan of deliberative theory, the Habermasian account of intersubjectivity and finding that balance between facts and norms and coming to intersubjectivity and agreement about what what we think facts are and what we think norms are, and that fusion of that. And that usually just needs spaces and political processes that are, have amount of open-mindedness, so ideology can work against that. But that idea itself is an ideology. So you need protective ideologies, but you need that politics and that space to come to terms with these things. Now we think about contestation as being a negative, but contestation actually requires reason giving at some point. And if it's in a broader process of intersubjectivity, then that contestation is helping us define the boundaries of what we agree on and what we don't agree on. And if done with a certain kind of openness and procedures, well, still self-interest and everything else is going to factor into things. There is optimism for positive change. And as social animals, we have figured it out enough. My only worry is whether or not, with things like epidemics and climate change and other global calamities that are on the horizon, AMR and things like that, whether or not that process is quick enough for us, or whether or not we've just taken too long and we're now being outpaced by the very challenges that we're supposed to be reflective on. And I guess the one hopeful thing I was thinking about is that, Ulrich Beck is a sociologist who wrote about risk societies. And maybe if risks, visceral risks like COVID-19, huge costs, 22 trillion so far and counting, loss of life, loss of liberties, felt, I'm trapped in my home. My grandma, my mom hasn't seen my grandkid, her grandkid. These type of things are huge costs. Maybe that World Risk Society, we're reaching that moment. Climate change may be too far on the horizon. This is now. And if mobilized properly and if the discussion is proper, then that could maybe form that kind of intersubjective moment where we can start to think through these things. And maybe the worst has to come first before that risk society. So maybe this whole last gasp of nationalism and populism is really a last gasp. And once that just dead ends, then the World Risk Society kind of starts seeing itself as more interconnected and our fortunes are more together, and we have to start thinking systematically at the global level, and et cetera, et cetera. How's that? That's my best optimism for you.
Hub, you're highlighted. Does that mean you would like to have a word? Or maybe it's just my screen.
No. What I liked a little bit was it was just mentioned leadership, and I gave a course to the students, fourth years medical students, whether female leadership was superior to male leadership in the corona crisis. It was very interesting discussions with the students, all kind of ideologies, all kind of presumptions. And of course, before I did a kind of literature search, and I found two articles, one in the Journal of Applied Psychology, Women Leadership is associated with fewer deaths during the COVID-19 crisis, quantitative and qualitative analysis of United States governors, in which male and female governors were compared. And then another article in PLOS ONE, Gender in the Time of COVID-19, Evaluating National Leadership and COVID-19 Fatalities. And although both articles don't agree and are stuck a little bit in complexity, it seems that female leadership was analyzed as being prompt, explanatory, empathic, and with a listening attitude. And there were correlations with, let's say, better outcomes. That was very promising to me because the world is becoming more led by women. So that could be a kind of side effect from that. Although the rise of populism and masculinity in politics may oppose that.
Well, I think it's an interesting perspective. It relates back to what Ron Heifetz, who is now a leadership manager, but by trade is a psychiatrist, said, leaders are not there to solve problems. They're there to facilitate the necessary adaptive work that people with a problem have to do. And that reminded me, it came to me when Garrett was speaking. It really is a matter of where are our leaders and how do leaders see their role in leading the discourse. Sort of the dialectic discourse has gone out of the equation completely. I remember at school we had to write it for 4 years. I hated it, but it left a mark. My brother, who is only 2 years younger, never heard about the term. Then he never had to do the same thing. I think it's that intellectual loss of stimulating debate, seeing a variety of perspectives that has been lost on society as a whole, and is potentially one of the reasons why we can have sort of the dogmatism coming out in fascism that's emerging again around the world. by keeping people stupid, some people with vested interests and sinister motives can succeed. I think that's a fairly clear-cut statement. I'm wondering whether someone is opposing that view and can enlighten me about more hope than I have at the moment.
Well, I'm going to offer a summary that offers a little bit of hope, pulling together a little bit of what our panelists have said, just in our sake of time, because we are over our 6:30 time period. But I think that some of the way forward is to create the liminal spaces Carmel has referred to that allow for some of the divergent, perhaps divergent ideas to be discussed, inviting the conflict that will lead to intersubjectivity that Garrett mentioned. And through that, we need to adopt the listening attitude that Hub mentioned, and perhaps it all just needs to be led by women. That's, I don't mind ending on that note, since I'm the moderator. How about that? And as much as I'd like to continue this discussions, I'm recognizing the time that it must be there for Hub. What time is it in the Netherlands now, Hub?
It's 20 minutes before 1 o'clock at night.
Yes. So I'm going to say that I'm going to thank the panelists very much for helping us make sense, and thank you for struggling with making sense of the questions in a way that will be meaningful for us. Thanks to everyone who joined tonight, and stand by for our next panel discussion in just a few months. We're planning that. And please feel free to reach out to any of us, Joachim, Carmel, myself, Jeanette's here on the board, if you'd like more information about the Society.